So we are live, sir.
Okay. Can I go ahead?
Yes, sir.
Good evening, everyone. It gives me immense pleasure to welcome you all to this webinar. I apologize for the delay. I also apologize for the fatigue or webinar trauma you are going through. But I'm sure today's one will be slightly different and Dr. Vivek will make it very interesting. I take this opportunity to thank Fisher and Paykel for giving me this opportunity to moderate this session and learn from it. When this pandemic started, I think we came across many newer things. We all came to know about self-proning, which we are now doing it on a day-to-day basis. We also came to know about the usage of HFNC in hypoxic respiratory failure. Though we have reasonable data in the last year about HFNC with regard to adult and pediatric patients, many of us did not have the machine. Though some of us have the machine, we did not put it into use. But the pandemic exposed us to the high flow nasal cannula. We all used high flow nasal cannula to a larger extent in many of our patients. And I take this opportunity to thank Fisher and Paykel for scaling up their operations and providing us with many units. Though there were a lot of need, I think the company scaled up their operations and they provided each of the clinician with the units they needed. So it was very helpful during the pandemic period. With this, we will go to the webinar. It gives me immense pleasure to introduce Dr. Vivek. Dr. Vivek, I know him for now 7-8 years. He is graduated from PhD Medical College. Then he went on to do his diploma in anesthesia in SMS Medical College, Jaipur. Then his further career was in United Kingdom over a period of 15 years. He did his fellowship from the Royal College in anesthesia. He also did his specialist training. He completed his European diploma in critical care, and also he went on to complete his fellowship in intensive care medicine from UK. His career spans over a period of 15 years. He has worked at various positions starting from senior registrar to a clinical lead. His areas of interest are teaching and training. He came to India before 7 years and he joined our team. He's been a pillar of strength to our team. And he takes the responsibility of teaching to all our fellows who are doing training in critical care. He's a very soft-spoken person with a clear head. He helps me in taking care of the day-to-day clinical and non-clinical problems. He's blessed with a son and daughter. The son has joined his medicine. He's in his second year of medicine, and he has a daughter, Tarini, who's about 8 years old, and his wife is a psychiatrist. Ratna is a psychiatrist. And with this few words, I would pass it on to Dr. Vivek for his lecture. Over to Dr. Vivek.
Good evening, one and all. Thank you, Dr. M. Shivakumar, for quite an extravagant introduction. I hope all of you are safe. Let me try and get presentation up. Hope you're able to see the screen now.
Yes, sir.
All right, thank you. So I think I take this opportunity given by Fisher and Paykel to present on high flow nasal cannula in critical care with a share of our experience as well. Thank the team, the intensive care team headed by Dr. M. Shivakumar and all my dear colleagues the fellows and the intensive care staff who have been vital in delivering a team care. So greetings from intensive care, critical care unit at Royal Care Super Specialty Hospital on this special day, this special evening. My overview of this talk will focus upon high-flow nasal cannula intricacies, although the word as such, the intricacies, means quite a lot complicated, but high-flow as such is quite a simple technique most of us practice. And what it entitles, what exactly does it entitle, and the role of HFNC in critical care, what are the different multitude of clinical situations that it can be applied potentially. And the most important aspect is to know exactly where high flow nasal cannula may not be an option, and the patient is unlikely to benefit from high flow nasal cannula. So if the patient has gone on to high flow nasal cannula, what are the predictors of that it's going to fail, and subsequently we need to escalate on the respiratory supports. And a brief mention of what our experience was in the last 10 months or so. So looking at high flow nasal cannula, it isn't as intricate as it sounds, because it has got very few components like the oxygen supply. There is a blender and it gives the dialed in percentage of oxygen. You've got the heated inspiratory circuit that goes on to give the patient the flow and the oxygen through a soft nasal cannula. The important aspect there being the active humidifier. So before going into depth, I think there are two important aspects to high flow nasal cannula. So one of them being the amount of oxygen that is being delivered, whether it is fixed or is it variable. So there are different array of oxygen delivery equipments that we know of, starting with simple nasal cannulae, where you dial in up to 4 liters of oxygen, or a simple face mask up to 10 liters. But with all these oxygen delivery devices, the amount of oxygen that is being delivered is varied. So the variability is because of the entrainment of the air that tends to happen due to the increased demand. So where does the demand increase? So during the inspiratory phase, there is a flow that tends to happen normally under normal physiological conditions. And the increased inspiratory flow is up to the level of around 40 liters to 60 liters. So that is where the difficulty is. So if you have to meet this demand, inspiratory demand of 40 to 60 liters, it has to happen at that time of inspiratory flow. So that's where the high flow comes in. So the flow generator in the HFNC tends to give this flow up to 60 liters easily. So it is able to maintain the flow or the demand that is required, and also the percentage of oxygen which is being dialed, be it 40% or be it 100%, that will be maintained. So that will be explained in the following few slides easily. So we can deliver a fixed percentage of oxygen, and the second thing is, the higher the demand, it can be easily met with the high flow nasal cannula. So these are the two things we need to mention here. So we've got a spectrum of oxygen delivery devices as we discussed. So where does exactly the high flow nasal cannula come into place? So probably it is in between the conventional oxygen therapy and the NIV form of ventilation, non-invasive ventilation, as we all know. But is that right? Probably not. I think probably I would argue that probably it is edging a little bit further down the line, almost in line with NIV, short of invasive ventilation. So that would be my case. So this picture probably depicts when there is a peak inspiratory flow of demand under physiological conditions, be it 40 liters, or maybe it is going up to 60 liters or even higher when there is a pathological process going on and there is a tachypnea, increased inspiratory flow happening, hunger is there. In those cases, I think even with a flow of 10 liters of face mask, will entrain quite a huge amounts of up to 50 liters or 60 liters, diluting the fraction of oxygen that you're packing in. So that is where the difficulty is. And that is where the high flow nasal oxygen will help. So say, for example, you have dialed in 60 liters of flow will match the demand, and the fraction of oxygen that is dialed will get delivered. So both the demand is met and the oxygen dialed in is met. Can high flow oxygen clear carbon dioxide levels? Yes, theoretically, yes. So you can see this picture where there is a depicted control group where you're dialing in around 15 liters of high flow. Then probably the upper airways tend to get cleared of the carbon dioxide level to a certain extent. And then if you compare it with 45 liters of flow, then even down to the lower airways, there could be a clearance of carbon dioxide. So with a higher flow, more the flow, CO2 elimination could potentially occur, but this is quite theoretical. I will explain why in the subsequent few slides. So is there a PEEP effect? So the so-called the CPAP that is being applied, so there is a continuous flow, and with the flow, is there an increase in pressure? So with this pressure, will it translate into a CPAP effect? Well, we have had quite a few studies which does mention if the HFNC is being delivered with a patient whose mouth is closed, then probably you're looking at 40 liters of flow will generate a pressure of around 2.5 centimeters of water. And then if the flow is increased to 60 with a closed mouth, then the pressures can go up to 3.7. So that is a significant amount of CPAP generation there. So that could splint open some of the closed alveoli. But if the mouth were to be open, which is probably not being followed up quite regularly by the bedside, that we need to urge the patients to breathe most of the time as much as possible with the mouth closed. So if the mouth were to be open, then the amount of pressure that is being generated will hardly reach 1.7 centimeters of water, even at a flow of 60 liters. So even at a 60 liters of flow, the pressure generated will be only 1.7 if the mouth were to be open. But if it is closed, it can reach up to 3.7. So the other picture, the forest plot, is to depict that the need for intubation or non-inferiority compared to NIV is pretty much matched, probably because of the pressure generation that high flow exerts. So that is something to note. So this slide is to just depict the same effect, that there will be a pressure generation, and at a flow of around 50 liters, the pressure achieved is somewhere near 4 centimeters of water. So with the mouth closed, the emphasis being the mouth being closed, a patient who is on HFNC can generate a reasonably a good level of pressure to splint open the closed alveoli. The most important aspect of the HFNC is the humidity factor. So constant humidification, so nearly achieving 100% humidity in the delivered flow, will help in the mucociliary transport of the sputum, and this is the most advantageous point if I were to highlight when comparing high flow against NIV. So this picture depicts, even if the humidity has to fall by around 10%, from 100 to 90%, within a duration of 15 minutes, the secretions can get stagnated, and the mucociliary function is quite a bit affected. So that is probably very well proven, and that would probably the limiting factor applying non-invasive ventilation per se. So this forest plot is to explain that HFNC clearly helps in reducing the dyspnea factor and also in reducing the respiratory rate as well. So these are two advantages that are gained by applying HFNC, and the comfort of the patient, very well able to cough and get the mucociliary effect, which is in place with a good humidification to clear up the secretion. So that is of immense benefit, especially in respiratory pathologies. So in a nutshell, just to encompass all those different aspects of high-flow nasal cannula, there is a good heated humidification of the inhaled gases, even if the flow were up to 60 liters, thereby reducing the metabolic cost of the breathing, and that tends to reduce the respiratory rate. Moreover, with the washout of the upper airways that we saw with the reduction in the CO2, so basically it is trying to at least reduce the dead space, and the minute ventilation, thereby exertion will also be reduced, and the work of breathing is reduced immensely. So the amount of metabolic work is reduced, thereby the oxygen requirement is reduced. So it goes in a cycle to reduce the respiratory rate eventually. And the high nasal inspiratory flow definitely reduces the resistance, improving the dynamic compliance, and thereby reducing the ventilator-associated lung injury as well. So with a good positive pressure, yes, the atelectasis can be reduced, and we very well know that we can deliver fixed inspiratory oxygen levels, be it 60% or 100%. It can very well be delivered with the amount of flow that has been dialed in. So in a nutshell, yes, it can improve oxygenation, it can reduce the dead space, reduce the work of breathing, increase the minute ventilation, and probably reduce the production of carbon dioxide itself. And definitely the compliance is much better, and the clearance of secretion is much better than the NAV mode. So if we were to initiate HFNC, briefly we'll look at how we initiate it. Like any other intervention, you do explain to the patient what we are going to do, and probably start with a lower flow of around 20 to 35 liters per minute, and the tubings should not be pulling on the nasal cannula which is being applied to the patient. So the soreness or the pressure sores don't happen, so immense care has to be delivered in those lines. And the FiO2 could probably be initiated at 100% if you had to start with, and subsequently the patient can be, most importantly, encouraged for a nasal breathing as against a open mouth breathing. So if you were to dial the flow, it can be increased in increments of 5 liters per minute to start with every 5 minutes, and subsequently it can be dialed in to the compliance of the patient, the comfort level of the patient. And the contraindications being, which we all practice on a day-to-day basis, which is alternate mentation. So that would be a clear-cut no to high-flow oxygen therapy if there is a facial injury, basal-skull fractures, and the conscious level has to be very well maintained. So that is a must. And the other contraindication being if there is a hypercapnic respiratory failure, PCO2 more than 45 would be a contraindication as well. And the patient subsequently, if you are looking at weaning off HFNC, then probably you would be reducing the FiO2 to start with. And if FiO2 is reduced to a reasonable level of around 50% or 40%, then the flow rate can be dialed down, and it can reach up to even 20 liters before switching on to conventional oxygen therapy. So that is briefly what we have seen, what a HFNC entitles, what are the physiological effects, what are the potential benefits that it can deliver. So what exactly has it got a role in critical care? So I would elucidate that these are all the numbered conditions that it could be used, and quite a lot of evidence does exist. So we will briefly have a look at all the evidences that we have got till date in terms of HFNC helping in these pathological conditions. So one of them being acute hypoxic respiratory failure in post-extubation status, cardiogenic pulmonary edema, obese individuals who are critically ill, palliative care, yes, quite a lot of evidence exists there as well. And prior to endotracheal intubation and post-extubation, there is enough evidences exist. COPD, yes, it has been tried. Bronchoscopy, it has been tried as well. So briefly, we will look at what are the evidences that exist. This is a landmark trial that was done in 2015, Frat et al. From France. Nearly 23 ICUs participated. They compared high-flow nasal cannula, NIV, and conventional oxygen therapy in acute hypoxic respiratory failure. So this was a reasonably well-conducted trial. The primary outcome that they looked at was, did these support measures prevent intubation? That was the primary outcome that they were trying to look at. And the secondary outcomes were measured, mortality, including mortality at 90 days as well. So looking at the Florally trial, the primary outcome was, of course, whether there was intubation, which was preventable. Yes, I think the intubation rate was lower in HFNC, nearly at 38%, whereas with NIV, it was at 50%, and with the conventional oxygen therapy, it was standing at 47%. So clearly stating that the intubation rate was lowest with high-flow nasal cannula group. And some of the secondary outcomes that they looked at was the ICU mortality and the mortality at 90 days. So both of them showed a beneficial effect with HFNC. So looking at the overall ventilator-free days at 28 days was also significantly better with the high-flow group as well. So looking at some of the weaknesses and the strengths as well, it was a pragmatic, well-conducted trial, which was a multi-center study as well. But in spite of that, there were a few weaknesses which probably had to be looked at. One is majority of the patients had pneumonia. So it was looking at patients, the majority of them being had one-sided pneumonia. Acute lung injury was the investigation group. So that was the primary aim of the study per se. But if you had to translate the same evidence to current data, I think there is a significant change in the ARDS definition per se, and we are not including ALA anymore within the definition group. However, the duration of NAV that was spent in one of the arms was less than 4 hours as well. So these are some of the weaknesses that was highlighted in this Florally trial. So results, yes, the high flow was not inferior to, definitely it is not inferior to conventional oxygen therapy or NAV in the need for escalation of respiratory care. So that was very clear. And then it definitely reduced ICU mortality and also the 90-day mortality as well. And definitely it improved patient comfort and the dyspnea factor. There was a post hoc analysis which also said that the low rate of intubation was especially in patients with PF ratio less than 200. So the moderate group benefited the most. So looking at some of the RCTs that do exist, which had involved high flow nasal oxygen and compared a few of them with the conventional oxygen therapy and some of them with NAV. We could look at the Florally trial, which was the seminal trial in 2015, and would like to highlight the Hernandez trials, which was in 2016, both of them done for 2 different groups, one of them being low risk for reintubation, the other group being higher risk for reintubation. So in these 2 groups, the lower risk group, they aptly grouped them into 2 groups where the high flow was one of them, the other one was conventional oxygen therapy. Definitely the high flow group had lower intubation rates in those groups. And the higher risk group, where the 2 arms of study was high flow versus NAV, at least they were able to observe that the intubation rates were similar in both the groups. So you could argue you are not worse off by applying high flow nasal cannula rather than NAV. So it probably matched the outcomes. So it is at least in par with what the potential effects were with NAV. So HFNC was not inferior when compared to NAV in those high-risk groups for reintubation. So there are quite a lot of RCTs which have been done with good numbers. So I would urge you to have a look at them for medical patients. So the meta-analysis do exist, and the meta-analysis comparing some 5 papers. It is a moderate heterogeneous meta-analysis involving 3 of them with respiratory pathology, 1 of them with an immunocompromised group having pathology, and the other one was post-surgical group. In spite of which, I think the HFNC, when it was compared with conventional oxygen therapy, the need for intubation was pretty much well favored by using a high-frequency nasal cannula compared to conventional oxygen therapy. When compared to NIV, definitely it was non-inferior as well. So HFNC was non-inferior when compared to NIV in this meta-analysis as well. So looking at some of the evidences that exist in the patient groups where you want to prevent reintubation. So looking at cardiothoracic post-operative group of patients, the BIOP trial in 2015 observed that HFNC was not inferior when compared to NAV. Looking at the OPERA trial for patient groups who had had subdiaphragmatic surgery, post-operatively, the reintubation is better prevented with NIV. So for subdiaphragmatic surgery group, post-operatively, reintubation was prevented better with NIV rather than high flow. Some of the critically ill group of patients, the evidence suggests that if the CO2 is being high, if it is more than 45 millimeters of mercury, then NIV is probably preferred over high flow. So that we have looked at as a contraindication, in fact. And then if you're looking at higher risk groups who are at higher risk of reintubation, then probably HFNC is better tolerated and definitely not inferior when compared to NAV. When you're looking at lower risk of groups who are at lower risk of reintubation in critically ill group, then HFNC definitely is beneficial. So when compared to conventional oxygen group, HFNC is definitely beneficial in these subgroups. So that is a kind of evidences that we have got as of now. And these are the group of RCTs looking at the preventive role. And these can be grouped into thoracic surgery, abdominal surgery, and cardiac surgery. So if I were to briefly mention thoracic surgery, yes, HFNC reduced length of hospital stay and reduced reintubations. Abdominal surgery, no clear evidence exists. Cardiac surgery, yes, 2 of them comparing with NIV, there is definitely non-inferiority compared to NIV use exists. So HFNC can clearly be used as against NIV as well. So looking at, is there a role for high flow in obese critically ill patients? Well, theoretically, you could argue it does cause a splinting effect, and it could probably be splinting open the collapsed upper airways. Does it make a difference in clinical outcome though? Probably not. So you could argue it could be opening up the alveoli, increasing the FRC, and increasing the end expiratory lung volumes. But the study done by Corley et al., which was published in Intensive Care 2015, probably the high flow did not help. So that is what we have got till date. So is there a role for high flow nasal cannula in bronchoscopy? Yes, there are a few papers suggesting it. Lucangelo et al., the PaO2 levels, saturation levels, PF ratios were better with 60 liters of high flow compared to 40 liters. So that is what they observed. Then Simon et al., NIV probably achieved better oxygen saturation than high flow in hypoxic respiratory failure patients. That was their observation. And subsequent use of bronchoscopy probably did not help for subsequent use. So probably high flow nasal cannula for bronchoscopy in critically ill there isn't much evidence suggestive that it could be used. Looking at pre-oxygenation in critically ill, well, there are quite a few papers, work has been done previously, but the bottom line seems to be that if the patients are on high-flow nasal cannula, you can very well leave them on high-flow nasal cannula, pre-oxygenate them, and then go on to intubate them, like we do normally with patients who are on NAV as well. However, it was not more effective in preventing desaturation episodes. So that seems to be the verdict from these previous work that was done. Looking at COPD patients. So what is the current evidence we have got for high-flow nasal cannula in COPD patients? Lee et al., they did compare high-flow nasal cannula and NAV. So probably it showed there was a carbon dioxide clearance which was similar when compared to both two supports at 6 hours and 24 hours. And the intubation rate and 30-day mortality was similar in both high-flow and NAV groups. And they observed that high-flow was not inferior to NAV in group of patients who were intubated for COPD exacerbation and subsequently extubated, and for maintaining post-extubation status, HFNC was not inferior to NAV. So I hope I have made that point clear. Lee et al. Observed that post-extubation for COPD exacerbation patients, HFNC was not inferior to NAV. And subsequently, Longini et al., HFNC instead of conventional oxygen therapy probably should replace NAV weaning. So if you're going to wean off patients on NAV, coming off NAV onto conventional oxygen therapy, HFNC has got a role. So hope that point is clear as well. So the highlight paper in 2019, giving a systematic review of high flow in COPD patients by Pisani et al., they did observe the real efficacy of HFNC is not very well established. However, the target population of COPD patients has to be ascertained very well. So we have to choose the right patients of COPD. So the pH has to be more than 7.25 at least. So it has to be ideally more than 7.35, which would comfortably be happy applying a high flow. But if it were to be more than 7.35, it could very well be applied. So high flow definitely reduces the work of breathing, similar to NAV. So those were the observations. And CO2 reductions did not happen. So let me emphasize, CO2 reduction did not happen with high flow in COPD patients. Let us move on to what kind of evidence exists in palliative care. Yes, dyspnea is a common important symptom that exists in terminally ill patients, which HFNC could alleviate. And endotracheal intubation is considered inappropriate in this group, where HFNC could play a role. And NAV does impair the communication and the feeding problems. So the work by Epstein et al., which was done way back in 2011, did show a significant improvement in this group of patients, and probably they maintained saturation better, the breathing frequency was brought down, and the compliance was much, much better in the subsequent work by Peter et al. In 2011, 2013 as well. So if you were to protocolize your use of high flow nasal cannula, this is a sample protocol where you're looking at 2, 3 yes and no's. So the first yes or no to be answered is there an imminent need for intubation? So if there is an imminent need for intubation, then there is a clear-cut no to high flow nasal cannula. So you're going down the route of intubating and ventilating the patient. So if there is no immediate need for intubation, then we are looking at initiating high flow nasal cannula, be it at a high FaO2 of 100% to start with, under 60 liters of flow, and a temperature of 37 degrees. And within, the key point there being within 1 to 2 hours, you are looking at monitoring the patient, reviewing the patient, both medically and by the nurses and by the respiratory therapists if you're luxurious enough, and monitor for prognostic factors. If certain prognostic factors like increasing respiratory rate, increasing work of breathing, increasing dyspneic levels, and clear-cut desaturations as well, then probably you've got a small window of opportunity of trying non-invasive ventilation for a short trial, be it for 1 or 2 hours. If there are no prognostic factors, you can continue with high flow nasal cannula with a saturation target of around 90 to 92%, and the flow rate can be adjusted, trying to achieve a respiratory rate less than 30, and the temperature can be dialed based on the patient comfort. The third question comes, is there a presence or absence? Is there a presence of prognostic factors or not? If there is a prognostic factors worsening, yes, you're hedging towards intubating the patient. If not, I think we can very well continue with the high flow, trying to wean down the FaO2 to start with. So this is a sample protocol which could very well be used in our ICUs. Well, having covered that, let us go on to an important aspect of high flow nasal cannula usage, which is failure prediction. So if you've got somebody on high flow, then we need to look at certain parameters which could predict failure of the ongoing high flow nasal cannula. So it could very well be a established high flow on a patient that you could predict it could fail, or whether initiating high flow itself could prove to be a failure. So with the next few slides, we'll dwell upon these few areas using the ROX index, looking at factors prior to application and post-application of high flow, some of the predictive scoring systems, and the high flow indication per se, whether we have got it because of a particular pathology or not. So looking at ROX index, it is quite simple. Above, we have got the saturation and the FaO2, and the denominator being the respiratory rate. So, for example, it is worked out here. If the saturation were to be 88, that is divided by the FaO2 in decimals of 0.7 divided by the respiratory rate. So that would give a ROX index of 4.48. So another key factor that comes in is what does it 4.48 mean? So it has to be quantified by the hours of HFNC that has been used. So is it after 2 hours of a high flow? Is it 4 hours after a high flow? Or is it after 12 hours of high flow? So that definitely matters. So over time, we have got few scores which have been validated. So at 6 hours of high flow, if you've got a score less than 3.4, then the positive predictive value reaches up to 99% that HFNC will fail. So if the ROX index is more than that particular number by that duration, be it 2 hours or 6 hours or 12 hours, then you are safe enough to continue with the HFNC. So the objective score with the HFNC prediction will be a ROX index, which is taking into consideration the saturation, what FaO2 you are giving, what is the respiratory rate of the patient. So looking at prior to application of high flow nasal cannula, what are the things that you will look at? So these factors like the SOFA score, SAP score, whether the patient is in shock already, if the patient has got severe ARDS, where the PF ratio is less than 100, or if the patient has got respiratory acidosis, pH less than 7.35 with the altered mentation, then you're probably safe not to apply high flow nasal cannula in these group of patients. But if you have applied the high flow nasal cannula in a certain group where you have ruled out all the poor predictors, then if you're looking at what could be the predictor of failure, then you're relying on the ROX index that we saw earlier. And then, is there a failure to raise in the PF ratio that was calculated before? So within 12 hours, you want to see an increase in PF ratio. So if that happens, then probably you are safe. Or you're looking at a clinical parameters of saturation less than 88%, respiratory rate more than 30, and there is a persisting dyspnea as early as 2 hours of high flow, then probably the high flow might fail. So positive predictive scoring systems, yes, few of them have quantified it as well, that probably SAP score is acting as an independent risk factor. So also, Koga et al. Did mention SAP score along with pleural effusion will be an independent risk factor again. And if you're weaning off invasive ventilation, then again, similar findings were observed. So pathology per se, there are certain indications. So you're looking at ARDS, acute hypoxic respiratory failure, PF ratio less than 100, probably it's going to fail. High flow nasal cannula in severe ARDS, PF ratio less than 100, it's probably going to fail. And if there is a persisting low PF ratio at 12 hours of high flow, again, it is going to fail. So this is relating to acute hypoxic respiratory failure group of patients. If you're looking at non-HIV pneumocystis coronary pneumonia group of patients, and if they've got a higher SOFA, and if there is a non-improvement of PF ratio at 6 hours, then HFNC is likely to fail. If you've got a post-operative group of patients and who have been weaned off invasive ventilation, and you're applying high flow in those group of patients, if you've got a higher BNP levels, higher SOFA levels, or a higher heart rate of more than 100 after 2 hours of high flow, then that is going to likely fail as well. So these are some of the clear-cut indications that we've got yet in literature as of now. So briefly, let me run through our experience at Royal Care Hospital. Well, we have been using high-flow nasal cannula for the last 10 months or so, since May, when COVID took us by surprise. And nearly around 90 patients had episodes of high-flow nasal cannula care in the COVID ICU alone, leaving alone the HDU group of patients where HFNC was also applied. And recently, we have started using high flow in non-COVID main ICU patients who are not COVID patients. And nearly 129 patients went through the COVID ICU, of which nearly 90 patients had episodes of high flow. And the average duration of high flow that was administered was around 4.5 days. And our experience with HFNC, there are a few things I had to mention. That initiation of high flow was after a thorough examination of the patients, be it through the monitor and through personal bedside assessments by the physician and the respiratory therapist by the bedside, taking into account all the vital parameters, and the nurses putting in their monitoring role as well. In initiating HFNC with the help of blood gas parameters and the vital parameters, which was observed over the admission to ICU. Along with that, we did take into consideration the acute physiological score. So that, as highlighted in the previous evidences, has got a huge bearing on if the patient is going to do well or not. For example, if the patient was in hemodynamic instability, is the patient in shock already? So all these factors from a multiple perspective, it was taken into account before initiating high flow nasal cannula. And subsequent monitoring was with bedside clinical signs of how the dyspnea is settling down, is the respiratory rate settling down, how are the vital parameters, and also using the PF ratio as measured with the ABG sample. And the escalation of care is something that needs to be hanging around all the time, that we need to take charge of the patient, making them safe if the high flow is not going to be helpful. So it is a continuous monitoring of the parameters, vital parameters, the clinical parameters by the bedside, with the multidisciplinary input by the respiratory therapist, by the bedside nurse, along with the physician, taking a call when to intubate those kind of patients or escalate the respiratory support for such patients. So we nearly had 23 patients, or 25% of those patients who had high flow requiring invasive ventilation, nearly 8.8% mortality among them, and 4.5% of AMA advised discharge against medical advice happening as well, for a variety of reasons. Another key point I wanted to emphasize is the prone positioning. So it is a multidisciplinary effort. The patients need to be coaxed, and they need to be taken by your side to prone them as early as possible, as long as possible, for these kind of respiratory supports to help in the overall outcome of the So if not prone, be it a high BMI patient, at least a semi-prone, at least a lateral position definitely helps the patients in the long run. So some of the patients who need to go on NAV, we found HFNC bridging was necessary while they were taking food break or for any kind of discussion with the over the phone with the family. All those times, HFNC has been of immense help as a bridging support in patients with NAV as well. So you could very well see the patients with the bedside high flow there, and the other patient on the right was not entirely comfortable with the prone positioning, so she was being managed on the lateral position as well. So some of the important considerations that one has to take into mind for the high flow to be successful is how many hours of high flow are we able to deliver, how many hours can we maintain them on, how many hours of associated support can we deliver in terms of prone and lateral positions, what are the associated treatments that they can manage, and what kind of local protocols can we keep in place for initiation, be it for monitoring the patient, how frequently do we need to monitor in terms of whether the HFNC is successful or not, whether to continue it or not, and taking the right step to recognize HFNC failure and supporting them with escalation of respiratory care in terms of intubation or ventilation. So those are important points to consider. And to summarize my talk, I think the HFNC has got a great potential in delivering beneficial role in multitude of clinical conditions, which we did discuss earlier. And it is definitely an effective tool in early, mild, and moderate type 1 respiratory failure in preventing further escalation of respiratory care. Definitely, it could reduce intubation rate in hypoxic respiratory failure patients, and also it can reduce the reintubation rate in postoperative patients. And I want to again re-emphasize needs a very close monitoring to identify failure and institute appropriate escalation of care, be it intubation and ventilation. And also, we will be wise in choosing the right patients for these kind of supports, and that will give a better positive outcome. So I thank my team, entire team, in helping me in day-to-day activities, helped by Dr. M. N. Shivkumar as well. And I would thank for the given opportunity. Thank you.
Thank you, sir. It was a. Sir, could you hear me?
Yes, sir.
Yeah. Thank you, sir. It was a very lucid presentation with very crisp and clear-cut messages. You took us through the whole spectrum of HFNC usage. I was surprised to see the patient subgroup where it was used like palliative care, etc. We also discussed about the practical aspects of initiation and objective parameters to look for treatment failures, and briefly you shared your experience as well. Well presented, sir. Now we can take questions if there are any, and request all the participants to post their questions in the chat box. I think there are a couple of questions in the chat box. Most of the things I think you summarized well during your presentation, but just for the sake of reinforcing certain important aspects. So, which group of patients benefited the most? And suppose you have both HFNC and NAV. So, how do you choose the patient where to use HFNC, where to use NAV?
Sure, sir. I think the type 1 respiratory failure group, where it is mild to moderate. So you're not looking at PF ratio less than 100. So you're looking at more than PF ratio of 100. So those are the moderate group of patients with type 1 respiratory failure. They are benefited most with high flow nasal cannula. So that is one of the groups. So next group being post-extubation group. So patients who are critically ill, we have extubated those patients who are good enough to endure no more intubations, but they are at a higher risk. So be it higher risk or at a lower risk, we are going to give them oxygen. So instead of conventional oxygen that they need, high flow nasal cannula definitely does help. If you're thinking about, do I need to give NIV or high flow nasal cannula for this kind of high risk groups who could probably risk intubation again, then the comfort zone and the compliance is much better with high flow nasal cannula when compared to NIV. So in these group of patients where post extubation there is higher risk as well, high flow nasal cannula is better with a better compliance when compared to NIV. So these are two groups I wanted to highlight.
Okay. Okay, sir. Basically, in patients with moderate respiratory failure, and particularly in the group who have got where you anticipate a post-extubatory respiratory failure, I think HFNC scores over NIV better in terms of patient compliance. I think
Absolutely.
So you did summarize about the treatment failure indicators.
Yes, sir.
Is there any contraindication for HFNC usage? I think that is one of the participants has asked. Is there any absolute contraindication for HFNC usage?
I think foremost, where everybody would agree, is there an imminent need for intubation? If there is an imminent need for intubation, just don't even think about high flow nasal cannula, like we do for non-invasive ventilation as well. So that is a pretty straightforward contraindication. Rest of the contraindications, one that has been highlighted in the talk as well was respiratory acidosis. So the carbon dioxide level is more than 45 mmHg. Again, because of lack of CO2 elimination by high flow nasal cannula, with the evidences that we have got, probably presence of respiratory acidosis is a no-no to apply in the first place. And if there is a reduced conscious levels, altered mentation, yes, again, we cannot apply high flow nasal cannula. And pretty much anything in terms of non-invasive ventilations, like for example, reduced GCS, the upper airway control in terms of there is a risk of aspiration, all these things will score as contraindications to applying high flow nasal cannula. Some of the places have did mentioned facial injury, extensive facial injury, basoskull fractures. All these things have been mentioned as a contraindication to high flow nasal cannula as well.
Okay. I think you have answered some of the other participants who have asked about the usage of high flow nasal cannula in COPD. I think with borderline slightly higher PCO2. You have answered that.
Correct.
Can you just briefly tell us, I think, the initial settings, how do you start with and how do you wean? Briefly, I think you mentioned in your lecture. Can you briefly tell that?
Sure, sir. I think the components of high flow nasal cannula, you've got the oxygen dial. So within my hospital setting, the respiratory therapist dials in around 10 liters of oxygen to start with. And then we've got to open the pack, and the machine per se has got up and lower buttons. On each of the machines will vary, of course. So you need to switch on the machine and start initiating the screen. And the screen might ask you to help in terms of dialing 3 parameters. One would be the FaO2, so how much of oxygen you want. So it could be could be around 100% to start with. You won't go wrong in that. And then the flow rate. The flow rate could very well be around 60 liters to start with. So the flow rate would be around 60 liters. FaO2 would be around 100%, which is 1.0. And then the temperature. So the temperature choice will vary something from 31 to 34 to 37. So you could dial it at around 34. And based on the patient complaints later on, you could choose to reduce or increase. So these are 3 parameters that you dial in as well. And then there is this humidifier chamber. And depending on the equipment that you use, in our hospital, we tend to hang a 500 ml bag of sterile water. And then that would feed the humidifying chamber. And depending on the high flow that you use, if it were to be around 60 liters, this bag will disappear within a couple of hours. So we are looking at supplying this sterile water for the humidified chamber, which could very well be using up huge amounts due to the high flow that you want the patient to benefit from. So it isn't costly either, but it is economical to use, but you might have to change it every 1 to 2 hours or so. And then from this chamber, which is generating the flow, which is humidified, you've got the inspiratory limb. So the inspiratory limb monitors the temperature that you deliver the gases at, and it ensures this temperature is maintained, the humidification is maintained. That ends in the nasal cannula, and the nasal cannula is made of quite soft material. You don't want any pressure or ulcers out of it. So that is strapped to the face, and the initial initiation has to be quite a lot of interactive way that we deal with the patients, where you tell the patient per se what you're going to do to help alleviate the symptoms of dyspnea and the reduced oxygenation levels, what you're exactly going to do, that what the machine tends to do, and then we are trying to apply these 2 cannulas. It is not going to hurt them, and that is going to help them. You need to keep them in place, and probably the associated beneficial effects of proning as well, rightly pointed out to them. And the most important thing is to highlight that you need to do a breathing through the nose with a closed mouth. So these are some of the practical aspects of initiating the HFNC. So to highlight the parameters that you would dial in: 100% FaO2, 60 liters of flow, temperature, mid-temperature range of around 34, and the flow being at around 60 liters can be initiated to start with a good explanation to the patient, with a closed mouth breathing. Is that good enough, or is there any other extra points needed?
No, sir. I think that was quite elaborate. There are some couple of questions from the nurses who are attending this webinar. So one of them I've asked about the nursing role and about the monitoring, which the nurses has to do with a patient who's on HFNC.
Absolutely. I think the foremost important thing is to have a multidisciplinary role. So being a nurse or being a doctor, or being any of the multidisciplinary team, I think one has to be aware that this patient is going to potentially benefit from high flow, and that is number one. And in close liaison with the respiratory therapist, who is in place in majority of the places now, you could continue with the high flow nasal cannula, which has been held in, with a key focus on picking up any leakage that happens, or any changes in the vital parameters that happens. Is the patient continuing to have a steady state of the dyspnea, or is it improving? What is the respiratory rate like? I am looking for a reduction in the respiratory rate in the next 1 hour or so. And I am looking at the saturation parameters. If the saturation parameter is going to worsen, I am aiming for around 90 to 92% of saturation with the set parameters. If these parameters, the targets being saturation of around 90 to 92, respiratory rate not worsening, and the patient's conscious level remaining status quo, being able to obey my commands, and there is no onset of shock that tends to happen. So these are some of the bedside things that I would observe. Alert the respiratory therapist to leak, and alert the respiratory therapist and the doctor for any potential deteriorations in the bedside parameters and the vitals that I observe. So these are the things as a nurse I would like to observe and alert appropriate people.
Thank you, sir. I think it is very important in any form of non-invasive ventilator therapy or oxygen therapy, at least during the early hours, the respiratory therapist or the nurse who's at the bedside need to closely monitor them clinically, as well as blood gas in the first second hour to see whether in which way they are trending. I think the clinical monitoring at the bedside is very important in the initial hours.
I agree.
One of the participants has asked how soon should we change the air filter. I'm sure, I think we will not be able to answer this. If there is any of them from Fisher and Paykel, could you answer this? How frequently should you change the air filter? I think we will get back to you. I think it depends on the running hours of the high flow nasal cannula. So let me check with the company person and get back on this. And another question to Dr. Vivek is, I think the concern during the early pandemic is about the usage of high flow nasal cannula and with non-invasive ventilation is the healthcare worker developing an infection. So I think how did you cope up with it, and do you see any of the healthcare worker contracting infection from the patient who's on high flow nasal cannula?
Very valid, pertinent question in the current climate that we live in, but more so, I think we dwelled on this aspect even before we started off using this high flow nasal cannula and be it NIV machines, the BiPAP machines that we used at that time. Yes, for the continued care of any of those kind of situations with the COVID looming around, yes, we need to take utmost care in terms of PPE. So on a day-to-day basis, how our day-to-day personal protective equipment usage is going to be and how it is going to be meticulously kept on a bedside maneuvers and a bedside management of such COVID patients is most important. So as a group, I think this was very well dealt with in terms of dealing with patients by meticulous training with the PPE kit, and then how you would deal with such patients who are on non-invasive ventilation. So the other facility that we did have was the isolation facility with a negative pressure rooms. So that tends to help as well. And then reducing the number of contacts between the patients and the healthcare worker. So you could time your bedside activities in a way that you've got the maximum protection on with the face shields and apart from the PPEs, the face shields and being in a negative airway pressure room will help reducing the contact with the patient per se. So it's a multitude of efforts that you take on a facility aspect and also on a personal healthcare care provision aspect that will reduce the amount of transfer of contagion. So you could very well negate those effects. So luckily, I could very well say that the healthcare effects during the COVID duration was almost nil. It was very, very minimal. It was kept to minimal.
Thank you, sir. I think there was a huge concern about the healthcare worker contracting infection from patients who are on high flow nasal cannula or NIV. And I think it was suggested to not to use high flow nasal cannula or NIV and to ventilate these patients from, if they're on face mask and if they need further oxygen therapy, I think straight away go ahead and ventilate this patient. I think this was the advice which came in very early pandemic. Huge concerns raised about healthcare worker contracting this. I think, but as you said, with proper infrastructure and taking adequate precautions, this can be dealt well. And none of our healthcare worker, I think, have developed infection from a patient. I think whoever has developed, I think they have developed from the community.
Absolutely.
Healthcare workers who are taking care of these COVID patient never contracted from the COVID patient. That was something which is reassuring. And I think the answer for the time duration to change the filter is 1,000 running hours or 3 months duration, or whenever there is a change in color of the filter. So when you have any of these, I think you need to change the filter. There's another question posted in the YouTube is about how do you wean, whether you wean the FiO2 or flow first?
Yeah, that's a very apt question, where I think it has been suggested in many of the protocols and the previous studies as well that you tend to reduce the FiO2 first. Okay, so you reach FiO2 of around 50%. So that is what is suggested. And although in practice we tend to reduce it to 40%, and then subsequently reduce the flow rates. So flow rates, you don't have to wait that you don't want to reduce the flow rate till I achieve a FiO2 of 40% or 50%. Not necessarily. If the respiratory rate is very well under control, if the respiratory rate is reduced, the compliance of the patient is good, the dyspneic factor is reduced greatly, then you could reduce the flow rate as well. But it has been suggested that you reduce the FiO2 first and then subsequently the flow rate down and to a rate of around 20 liters, even down to a letter of 20 liters before switching them on to conventional oxygen therapy.
Thank you, sir.
Thank you.
I think there is another comment in the chat box from respiratory therapist Vijay. I think what is posted is when you go for self-sterilization, I think the need for changing the filter will be indicated. I think that's a very useful feedback. And if there are no further questions, I think we could wind up. One last comment. I think one other group of patients, as Vivek mentioned during his lecture, I think in post-extubation patients, high-risk patients where you're expecting a respiratory failure, who need high flow, who need higher level of oxygen, like 10 liters, 15 liters. So, and these patients, elderly patients who are at high risk for post-extubation failure, these group of patients benefit significantly from high flow oxygen therapy, high flow nasal cannula. Usually what we do to these patients is these patients are continuously put on NAV for days together, and humidification is an issue, and these patients upper airway gets dried up, and probably there is a huge crust, a thick mucus formation, they're not able to cough, and ultimately they land upon a ventilator. So these group of patients, high risk patients, at risk, high risk for post-extubation respiratory failure, they benefit to a larger extent from high flow nasal cannula. I think any final word from Dr. Vivek?
I totally agree with that. I think that is a clear-cut indication that we tend to see off late in main ICUs, non-COVID patients, post-op patients who are at risk of getting reintubated. So the utmost benefit that we could have from high frequency nasal cannula is the patient comfort and the presence of humidification that tends to help with the nasociliary function and easy clearance of secretions. So most of the time when we tend to intubate such patients as well, we do see quite a lot of clogged up secretions, dried up secretions. So it tends to reduce the swallowing per se. So it's a multitude of effects, after effects that tend to happen after drying up of the upper airway secretions. So that tends to have a huge bearing. Yes, I agree. I think in these group of patients, high flow will immensely help. I agree.
Thank you, sir. I think with that, we have come to the end of this webinar. To sum up, I think the high flow nasal cannula seems to be a very useful tool at the bedside. The pandemic has exposed us to this tool, and we are all of us are gaining experience. And as discussed during the webinar, I think careful patient selection is very important for the success of it. And we do need to closely monitor this patient once you initiate them on high flow nasal cannula, and switch over to invasive ventilation when needed, I think, to prevent a catastrophe. So in this aspect, the close monitoring and switch over to invasive ventilation whenever appropriate. And I request all the participants who were using this tool to share their experience, so that I think it will be useful for further usage and patient care. I think with this, we end this webinar. We thank all the participants. Hope this is useful to your clinical practice. And thanks, Dr. Vivek, for such a nice presentation. I also extend my thanks to Fisher and Paykel for hosting this webinar. Thanks, everyone.
Thank you, both of them, like both of you, sir, from FIRST Academy. So, thank you very much.
Thanks a lot.
Thank you.
Thank you.